At the outset, I would like to congratulate Dr. Shabir, Dr. Sanket and all the team for organizing a very important thrust area in the field of the rheumatology. My topic of my presentations will be on dynamic knees, revolutionizing the physiotherapy, exercise as medicine. This is the outline of my presentation. Knee complex, what are the important rehabilitation perspectives during the assessment and the management, what are the important rehabilitation approach, advances in the physiotherapy assessment and management, applications of AI or the digital technology in the management, and the summary. This has already been discussed by the previous speaker. The most importantly, from the rehabilitation's point of view, whenever we start assessing the patients or treating the patients, it is important for us to know what stage of the osteoarthritis the patient is suffering. It is when we say the severity of the joint, the changes in the or the reductions in the articular surface, just not restricting only to the joint space or the formation of the osteophyte. It's also an important in terms of the dynamic control of the knee joint, in terms of the surrounding soft tissues, not just restricting only to the knee, proximal and the distal aspect, both the musculatures which cover the hip as well as the knee complex also. So another important aspect is to look at the knee risk factors and also look for the various symptoms, whether the patient is having a gradual onset or worsen with the activity, stiffness and the swelling, prolonged sitting as the resting, whether it aggravates the pain as well as the any other structural damage. So one important aspect with respect to the physiotherapy assessment is look for the nature of the pain, predominantly whether it is a mechanical pain or whether it is related to the inflammatory pain. So osteoarthritis can develop either with the degenerative changes or with the inflammatory, predominantly in the rheumatoid arthritis. Then look for other changes in terms of the swelling, the instability with the various clinical tests, and most importantly the measurement of the quadriceps angle is very, very essential. Look for the change in the angle, anything more than 15 degree, and also look for whether there is any significant genu varum, and these 2 points are very, very important because genu varum can also lead to a significant change in the IT band length and in the function. Therefore, and also it can lead to the one of the lower extreme or the foot changes in terms of the subtalar overpronation. So that these 2 points also needs to be taken into the considerations while assessing and the rehabilitation. In addition, these all the important measures can be taken to know the prognosis of the patient. Most importantly, we miss this point. What is the level of physical activity of an individual? This needs to be in the, as I said, an exercise as medicine. In the first slide I mentioned, because according to the American College of Sports Medicine, like how we are measuring the vital signs, the physical activity level also needs to be a part of the vital signs in all the patients' population, because now the non-communicable disease is significantly increasing, and one of the most common, the risk factor is the reduced physical activity. Look, what is and before we, especially before we rehabilitate the patient, whether the patient is having a sedentary or whether the patient's, what is the activity level of a patient, and most of the time we see they have a sedentary behavior, and if you look at the physical activity level, it is significantly reduced in terms of less than 600 met minutes per week. So when we start rehabilitating, first we have to change the physical behavior of an individual before we focus on any other graded rehabilitation. So, and also we look for the severity of the other associated factors using the either knee, the KOOS score can be used or the OMAC can be used. In this, I am starting with one case discussion, how exactly we assessed and rehabilitated him. He is an Yakshagana artist of the local drama. There more than 49 years and he can't able to live without performing the Yakshagana, and when in the Yakshagana that activity significantly puts more load on the lower extremity. When we evaluated him, this is the changes he had, and the rest as well as the the numerical pain rating scale was significantly high during the activity. So in our center what we do is first we screen for the skeletal mass index in all these patients, because before we are rehabilitating the patients, it is important to know the segmental changes in the muscle mass. The skeletal muscle mass, as I said, the dynamic control of any joint is basically by the important muscle. So in this case, if you look at, there is a significant reductions in the lower segmental skeletal mass index, and quadriceps, the gluteus medius and minimus had a significant impact, and this is one of the muscular cause for him to aggravate the pain or get the increase in the pain during the activity also. This is called usually the in-body measurement, where we can able to measure the skeletal mass index, the fat mass, and all other parameters which are essential from the rehabilitation's point of view. Then we also did the pain perception threshold, basically to know whether the peripheral sensitization, and this also, as mentioned by previous sir, the cognitive behavioral therapy, because the pain has both body and the mind. When we rehabilitate them, we have to look for both the aspect in terms of the counseling or the pain science education play an important role in these patients. Then the detailed assessment of the patients we did in terms of all this, the range of motion, the flexibility, the muscle strength, all are very, very important. This clinical assessment needs to be done before we start any rehabilitation. In this case, there is a significant reductions in this, both the knee, the hamstring as well as the quadriceps, and the iliotibial band, especially the vastus lateralis, gluteus medius minimus, and the tensor fascia lata, they have the grade 3. And range of motion is also. The patellar mobility needs to be assessed, because most of the time, even though I have a significant genu varum, there is a significant change or the malposition of the patella. This is one, as the specific exercise needs to be focused on getting the patellofemoral control also. Then we also do the detailed biomechanical assessment, because in these cases, sorry, can we go back to the previous slide? Yeah. What we do is just, it's a 3-step gait analysis. We ask the patients to walk on the pressure mat and gives a lot of information related to the knee, the range of motion or the joint angle, the pressure distribution, as well as most importantly, the sway velocity, because all these patients, along with the changes in the range of motion, changes in the muscle mass, they have the fall risk is also very, very high. The fear of fall is also very, very high. And we also go for the detailed biomechanical assessment to understand the change angle change in the different motion. Then the next, the static pressure analysis, because as I mentioned in the beginning, the knee joint can also alter the significant changes in the foot and ankle as well as the hip. When we rehabilitate the patients for the osteoarthritis, our focus should not just only on the quadriceps strengthening, focus needs to be on all other major group of muscle, thereby the overall function and the quality of life of the patients will be significantly improved, and also the pain perception or the pain perceptions will be significantly reduced. Then we also do the time up and go test. Basically, normally it should be less than 9 seconds. In this case, he had a significant increase in the time. Also, this is one of the reasons for an altered balance in this case. Then the functional capacity, we usually do the 6 minutes walk test. And in our center, what we did is we also developed a newer kneecap. The kneecap, most of the time, it has about 6 inch. Ideally, it will not cover not only just cover only the patellofemoral and the tibiofemoral joint, but in most of the time, very important to control the dynamics of the calf muscle as well as the quadriceps is very, very essential during the ambulations. What we did is we developed a 21-inch length of the kneecap. This almost comes up to the mid calf to the mid thigh to the mid calf, and during the ambulation, almost based on our plantar pressure analysis we did, 30 to 40% of the weight reductions we can see in these cases if they have a very the long kneecap as compared to the existing one. Existing one helps in relieving the pain, but in terms of the weight distribution, it have only a maximum of 15%. The physiotherapy management should focus with the detailed assessment, should focus on the management strategies, should focus on two aspects. One is an inpatient or the supervised rehabilitation. The second one is the self-management strategy. The pain management, mobility and strength, functional capacity, quality of life, and then the social participation. The self-management strategy needs to be on the understanding the conditions, proper education, proper ergonomic advice, self-care, and then the other two aspects we can also include for the remote monitoring, the role of digital technology and the fall prevention strategies. Rehabilitations can be divided into three different stages: the phase 1, phase 2, and the phase 3. Normally, irrespective of the duration of the pathology or the history of osteoarthritis, what we do is we divide into the three important phases. The first one is called the early function recovery phase. It can go up to a maximum of 2 weeks, but most of the time the patient gets relief of pain by 5 to 7 days, and then we can progress with the exercise. The second phase is the progression phase or the recovery phase, and then can go up to the 6 week, and then advanced functional phase or the maintenance phase can continue for a lifelong. Why this is important is the tissue healing, irrespective of the pathology, whether it is an acute or the chronic inflammation is the major challenge for the persistent pain. Therefore, what we do is, irrespective of the duration of the pathology, first focusing on reducing the chronic inflammation and then start the exercise. Otherwise, directly during the chronic inflammation, if we just start the exercise, it can sometimes the inflammatory markers can get provoked. Patients may not get much significant benefit in terms of reduction of the pain. So one important strategy, there are various modalities are available, but what in our centers what we do is, the surge Faradism play a significant role in improving the end range mobility, as well as also helps in relieving the synovial thickening. Most of these chronic osteoarthritis patients will have because of the persistent synovial leak or the effusion, even though synovial effusion leak stops, but when they persist with the chronic synovial thickening. The end range contractions along with the active terminal knee extension with the surge Faradism helps in relieving this chronic or the synovial thickening. It reduces the synovial thickening.
Dr. Maiya,
thereby,
2 more minutes, please.
Yes, sir, just quickly. Then the next, we focus on the photobiomodulation. As compared to other modality, this has the depth of penetration is more. It has more than 6 centimeters of depth with the different wavelength. Even we can reach up to the articular surface. So in case if there is an osteoarthritis, mild to moderate osteophytes, even with the help of the applications of the laser therapy, we can able to help in remodulating or reducing the osteophytic changes. Then the early based exercise can focus on the aerobic, strengthening, flexibility and the balance and the proprioception. So this is the one exercise very, very important. Hamstring stretching is very important. Camshell exercise basically focusing on the gluteus medius and minimus. These all the exercise patients themselves can do at home also. This, as I mentioned in the beginning, don't just focus only on the quadriceps, focus on the other major group of muscle so that the overall control of the lower kinetic or the kinematic chain will be very good. Then we go for the straight leg raising as an advantage of two things. One is it helps in improving the rectus femoris strength. Then at the same time, the SLR will also helps in controlling the core muscle, especially the transverse abdominis and the obliques. When we do the SLR, have an important core control also will be attained. Then we progress to the high sitting quadriceps strengthening. Here 2 aspects we can do. One is called the short arc exercise, where the 30-degree knee flexions to the full extension. The second one from the 90-degree to the full extension. Okay. Sorry. This all the hamstring curling exercise, then the hip abductors exercise, and then the hip extensor exercise. This needs to be gradually progressed. Okay. I think with the time constraint, I will skip the videos. Okay, hip abductor. Then after 2 weeks of this training, then we need to progress with the 10 RM, the 60%. Initially we can start with the 10 RMs, 60% of the weight, and then gradually we progress with the strengthening program. Okay, then this all the various. Okay, then the closed kinetic exercise usually starts after 4 weeks of this initial phase of rehab. Then we will go with. Ideally, we should avoid the treadmill. Most of the time patients will ask whether can I be able to do the treadmill. Ideally, we encourage the cycling will be a best exercise as compared to the treadmill, because treadmill during the inclination, even a 5 degree of inclinations can significantly lower the patellofemoral joint, and it can worsen the osteoarthritis or the structural damage. Therefore, ideally the treadmill is not recommended in the osteoarthritic patients, but the bicycle exercise is the best exercise as we progress to the graded rehabilitation. Okay. Last component is the balance exercise, and this all the various balance exercise we progress. Then the patellar mobility. Okay. Then the surrounding muscles, soft tissue manipulations, and the trigger point release as and when required, that we need to be included along with the other exercise management. Dry needling is also an acceptable thing, but the level of evidence is not very strong with respect to the osteoarthritis. But it can help in initially the trigger point can be relieved with the. Okay. Then in case if required, the taping is also another approach we usually do. Okay, this is the walking or the gait rehabilitations with the. Okay. The last one is the customized insole, because when there is a severe genu varum, the genu varum needs to be corrected with the lateral wedging. There are two important advantages. One is it helps in reducing the loading on the medial joint space, and also, as I said, as the genu varum increasing, there is a foot will go for the overpronation. The lateral wedge will prevent the subtalar overpronation. At the same time, it helps in reducing the load on the medial joint space. A simple footwear modifications can be given, or the insoles can also be given if the patients are wearing the shoes. Okay, this is the advanced thing with respect to the knee care. Then the activity modification, maintenance programs to the digital technology. In our center, we have developed our own technology called the CASAMED. In this, all these exercises can be controlled even from the remote. The patient not necessarily come to our center regularly. So we will be able to monitor this exercise in a remote method, and also we can able to check their adherence to these programs properly. So in summary, osteoarthritis of the knee need to be evaluated and provided with the preventive, joint protection, ergonomic, customized exercise-based program. Therefore, it can be a preventable condition. Detailed clinical and the biomechanical assessment, corrective footwear modifications for the preventing and controlling the varus deformity. Patients with other comorbidities, if they may be having the diabetes, hypertension, obesity, or patients with the significant BMI more than 25, physical activity level needs to be encouraged for the in the early physiotherapy screening needs to be done. So clinician have to assess the physical activity habits, inform patients of risk, and refer for the proper exercise prescription. In case whenever you are referring the patients to the physiotherapist, the stage of the OA may be an appropriate thing. The other comorbid conditions or the medical history. So accordingly, the exercise modifications we focus. Physiotherapist needs to educate the patients regarding the proper exercise prescription, adherence to the programs, and then the ergonomic advice. Okay. Thank you all.